So for the next 20 minutes, I'll be talking on dyslipidemia and ASCVD, flashback and vision ahead. So let's see why we are so much concerned about lipids. The first reason is that cholesterol never sleeps. It works 24/7 and executes its ravages on the cardiovascular system in terms of plaque formation in the arteries. Still more important reason is that plaques are the major culprit for cardiovascular disease. They put us at risk of heart attack and stroke. And all of us know heart attack is the #1 cause of death and stroke is the #1 cause of disability. The second more important reason why we are so much bothered about dyslipidemia in the current era is that lipid management for ASCVD has reached great strides. So when we look at the issue, can we stabilize the plaque by lowering LDL? The answer is a big yes. And there's plenty of data available with statins. Secondly, when we look at the issue, can we reduce the plaque buildup? That is, can we arrest the progression of atherosclerosis? The answer is again yes. Data from the reversal trial clearly showed that high-intensity atorvastatin showed arrest of progression of atherosclerosis. When we look at the issue, can we shrink the plaque by lowering LDL? That is, can we achieve regression of atherosclerosis? The answer is again yes. And we have excellent data from the Glegov trial. Statins plus evolocumab showed regression of atherosclerosis. Can we make the plaque disappear by lowering LDL? This is an unresolved issue at the present state of time, but you never know, this may become a reality. As a consequence of all these important research, currently we are running the race virtually to the bottom of LDL in the high-risk ASCVD. So when we look at the issue of the target of ACC-AHA 70, Lipid Association of India 50, ESC 55, ESCAS also gave a special target of 40, those who get recurrent ischemic event despite high-intensity statin within the first 2 years. And the Lipid Association of India 2021 created a extreme risk group where the target is 30. The beauty of lipid management is there is no J curve. That's why we say lower is better and lowest is the best in the high-risk patient. So when we look at the evolution of lipid guidelines during the last 35 years from 1988, when ATP1 came into existence to 2023, what do we find? LDL is the primary target. Non-HDL is the co-primary target. HDL cholesterol is a fallen angel because all trials of HDL elevation pharmacologically are flop trials. They did not improve outcome. Triglycerides is still in search of a positive randomized controlled trial. The prominent trial was negative. The stent trial was negative. The reduced trial, no doubt, was positive, but the mechanism was not related to lowering of triglycerides, as you can see here. What about LPA? Yes. LPA, at the moment, there is no evidence-based target, but the Horizon trial with pelacarsen is ongoing, and hopefully if it comes out to be positive, pelacarsen will emerge as a transformational therapy for LPA-induced deadly cardiovascular disease, and then we will have an evidence-based target for LPA. What about ApoB? ApoB, there's a green light, and in times to come, it will replace the conventional lipid profile, which means LDL cholesterol and non-HDL cholesterol will disappear, and the lipid profile will contain ApoB, ApoA1 ratio, and LPA once at the age of 18 years or so. Statin is the foundational therapy, and the king statin can never be replaced. Because statins have multifaceted actions, they decrease LDL synthesis by inhibiting enzyme HMG coenzyme reductase. So they improve endothelial function, decrease LDL cholesterol, they delipidase the plaque, as you can see in this vascular MRI. This is before statin and this is after statin. The same thing was exhibited by the yellow trial from Mount Sinai. You can see the lipid core index showed a decrease after statin therapy within a period of 4 weeks. They also pacify these hot plaques, which can be seen on PET CT. This is an example of hot plaques. We use statins that can be pacified. They also promote calcification of plaques, which decreases their propensity for rupture. And they have a lot of pleiotropic effects. And what is not widely circulated is they also decrease the thrombogenicity of blood, so that in the event of a plaque rupture, the probability of a plaque rupture culminating in acute coronary event is decreased. And they also have a legacy effect. Excellent data from the Vascov trial, 20 years follow. You take statin for 5 years, enjoy the legacy effect for the next 20 years. So no doubt statin is the foundational therapy for lipid management, but LDL goals are not achieved in statins in 50% of the patient, as you can see in these trials, the DICEs or the SAPHIAs. But those who achieve the goals, there decrease in the morbidity and mortality. So when statins fail to achieve the LDL goals, ezetimibe is used. And if ezetimibe and statins fail to achieve the goal, in past we used to use PCSK9 monoclonal antibodies, but now bempedoic acid is used ahead of PCSK9. This is the improvement trial. All of us are aware of it. It showed a statistically significant reduction in the primary endpoint by 6% when ezetimibe was combined with simvastatin compared to simvastatin alone. And this is the data. You can see non-fatal MI, the yellow one, significantly reduced, p-value is significant. Non-fatal stroke, again, significantly reduced. Revascularization, there's a numerical decrease, and unstable angina, not much change, and so also the cardiovascular death. Bempedoic acid is a new kid on the block, is already approved by various guidelines for HeFH or established ASCVD requiring additional lowering of LDL cholesterol, and now is also approved for statin intolerance after the CLEAR outcome trial. The peculiar feature of bempedoic acid is that it is a prodrug and is activated by the ACVL1 into its active form, the bempedoyl coenzyme. And this enzyme is not present in the skeletal muscles, and therefore it does not contain muscle toxicity. And it eliminates the synthesis of cholesterol by blocking the ACL enzyme and decreases LDL cholesterol. The only important side effect is hyperuricemia and gout. All other side effects are rare. It is not diabetogenic, rather it decreases the incidence of new onset diabetes. Tendon rupture is a very rare complication, but a serious complication, and usually occurs in some subset of patients if you are an elderly, taking steroids, fluoroquinolones, renal failure, or history of tendon rupture. And if there's slightest suspicion of tendon rupture, the drug should be stopped, or if there's slightest signs and symptoms, it should be stopped. But peculiarly enough, the CLEAR Serenity and the CLEAR Tranquility trial had no tendon rupture, which was carried out in statin intolerant patient. And bempedoic acid should not be used concomitantly with simvastatin more than 20 or Prava more than 40. And here's a case report that is not seen only with bempedoic acid. Simvastatin with ezetimibe is also associated on rare occasions with a tendon rupture as a tendo Achilles. This is the CLEAR program, all the 4 trials of bempedoic acid. The 2 trials in statin-tolerant patient, the CLEAR Harmony, the CLEAR Wisdom, and 2 trials, the low one, statin-intolerant patient, that is CLEAR Serenity and CLEAR Tranquility, and 20 to 30% patient in all these 4 trials were diabetics. What is the LDL reduction? Simple rule. If you use on top of maximally tolerated statin, bempedoic acid reduced by LDL by 15 milligram per DL plus minus 2. So here you can see 16.5 and 15.1. If you use it in a statin intolerant patient, the reduction LDL is much greater, 23.5 or 23.6, because both the drugs act on the same pathway. So if you are using in statin intolerance, the reduction in LDL is much greater. On the other hand, when you combine both these agents, that is bempedoic acid and ezetimibe, the reduction may be tune of 35 or 36%, as you can see in this slide. The additional advantage of bempedoic acid is it also decreases H high sensitivity CRP. You can see on the left, statin tolerant patient 22% and 18.7, on the right 32 and 25.4. This is an additional advantage. And statin intolerant patient, I've already told you, it may be decreased to the tune of 36%. So what could be our strategy if we face a patient of statin intolerance? In the Indian context, the simplest strategy is pitavastatin, which does not produce statin intolerance, combined with ezetimibe and bempedoic acid, and this produces substantial reduction in the LDL cholesterol. As you can see in this Australian trial, LDL with this combination, bempedoic acid 180, ezetimibe 10 milligram, and atorvastatin only 20 milligram, decrease LDL cholesterol by 63.6%. 90% of patients achieve the LDL goal of less than 70, and 58% achieve the LDL goals of less than 55. There are also favorable changes in the other lipoproteins. And this is the clear outcome trial, which is positive. So we have a positive trial of bempedoic acid in statin intolerant patients, and now as a guideline-based recommendation. This is the baseline characteristic of this trial. You can see bempedoic acid in this trial at 26% reduction in LDL and substantial reduction in the HSCRP also. The 4-point MACE was positive, showed a statistically significant reduction of 13%, and the 3-point MACE cardiovascular death MI stroke also 15% reductions, which is statistically significant. Fetal and non-fetal MI also showed statistically significant reduction at 23%. Coronary vascularization 19%, which is significant. But fatal and non-fatal stroke only a numerical reduction of 15%, and hospitalization for angina also a numerical reduction of 34%. Cardiovascular death, all-cause mortality was not altered. Adverse effect, as we said, bempedoic acid only has some elevation of uric acid and gout. Other side effects are very rare. And therefore, the clear outcome trial shows positive results in statin intolerant patients. PCSK9, the achievements of PCSK9 monoclonal antibodies, evolocumab, which is available in India, elerocumab, which is not available. Reduction in LDL to the tune of 40 to 60% on top of all lipid-lowering therapy. Reduction in LDL translates into additional reduction in CV events. LPA decreased by 25%. Favorable change in all other lipoprotein, good safety even up to LDL 10 milligram, as was demonstrated by the FOURIER subgroup, and no diabetogenicity or muscle toxicity. This is the FOURIER trial in stable angina, which shows positive results. It is the ODC trial, post-ACS patient, 1 month to 1 year, and again showed positive results in the ischemic endpoints. And this is the AVOPEX trial in patients with ACS, which showed that it produces substantial reduction in LDL cholesterol. And several other trials have been tried, and PCSK9 has become the standard of care in high-risk ACS patients where LDL targets cannot be achieved by other therapies. For FH, this is HO homozygous HF. This is a wonder drug, evenocumab, because the effect of evenocumab is independent of LDL receptor density and is likely be due to promotion of VLDL processing and upstream clearance of LDL formation by inhibiting lipoprotein lipase. So this is a boon to patients of homozygous. 15 milligram per kilogram once a month, but not available in our country and is very expensive. Inclisiran is a new wonder drug. It inhibits the synthesis of PCSK9 in the liver. And the beauty of inclisiran is it has unmatched adherence because it provides sustained decrease in LDL by 50%, which remains there for the next 6 months. So 1 injection every 6 months is the way to go. Reduce-it trial with icosapentaethyl 2 gram twice daily showed positive results in the primary endpoint. As you can see, the primary endpoint cardiovascular death, non-fatal MI, non-fatal stroke, and coronary vascularization, unstable angina in patients of established CVD or diabetes with risk factors and hypertriglyceridemia, TG. You can see 135 to 499, and most of these patients are on statin with LDL 41 to 100. The secondary endpoint also shows positive result, 26% reduction. But what was very curious is that the benefits of triglyceride was not related, the benefits in the trial was not related to triglyceride. So whether your triglyceride is more than 150 or less than 70, the benefits are same, clearly indicating that the positive results in reduced trial are not related to lowering triglyceride, but some other actions of icosapentaethyl. And you can see the positive results of the reduced trial. All hazard ratios are to the left, which is very rare to see in our day-to-day practice. PCSK9 vaccine is a new innovation. A single vaccine decreases LDL by 50%. It remains there for 1 year, and therefore, if the human trial comes out to be positive, a booster dose every year would be a new way to treat atherosclerosis. Seladelpar is only available in India and not in the Western countries. It's approved in India for clinical use in patients with diabetes, for hypertriglyceridemia, and for NASH. And it produces great reduction in triglyceride, 45 to 60%, and also decreases blood sugar by 0.7 to 1.6. LPA-driven cardiovascular disease is a serious problem because this is a deadly disease. But an LPA-driven cardiovascular is considered a slow death sentence with gloomy prognosis because of background progression of ASCVD and also AS. But pelacarsen is likely to emerge as a transformational therapy for this subset of patients if the horizon trial comes out to be positive, and it is an antisense to ApoA, and that is the mechanism of action. The phase 2 trial was positive, and it showed that LDL goals, LPA goals less than 50 were achieved in 98% of patients. And the phase 3 horizon trial is ongoing. We're keenly awaiting the result of pelacarsen. Gene editing has emerged as a very exciting modality because it's once done and the patient treatment is over for the rest of his life. So it's a big stick with single treatment. And gene editing by CRISPR technology, I will show you the video, is the future of cardiology. The first prize in the first patient in New Zealand has already been undergone PCSK9 gene editing with excellent results, and the hard one trial with one is ongoing. And the credit for this PCSK9 gene editing with CRISPR technology goes to these European ladies, Emmanuel Charpenter and Jennifer. And this technology basically has two components. The first component is a guiding RNA, which is composed of guiding RNA and Cas9 protein. The guiding RNA guides the Cas9 protein to the specific genomic locus where the Cas9 nuclease induces a double-stranded break at the specific genomic target. I'll show you the video. Now you see the guiding RNA will locate the specific genome. It has located and the Cas9 nucleus has produced a double-stranded break. And when this hits, the PCSK9 loses its function. It becomes a case of loss of function of PC9. And for the rest of the life, the LDL is reduced by 50 or 60%. And this has a great beneficial effect on atherosclerotic cardiovascular events. So the trial is already going in New Zealand, and this may be the future of cardiology. The gene editing is not only for PCSK9, for other gene disorder also. When we look at lipid-lowering therapies, we use statins, oral therapy, we have ezetimibe, icosapentaethyl, bempedoic acid fibrate. These are once daily doses. Icosapentaethyl, of course, is twice daily. And then we have the monoclonal antibodies, the alirocumab, the evolocumab, and the aviniquimab monthly or bi-monthly. And we have weekly or monthly. The antisense therapies, volaniposan, vupasan, and pelacarsen, and biannually inclisiran, gene editing, gene vaccination, PCSK9 is annual, and gene editing is for the rest of the life. So at the moment, we have LDL as the main target, non-HDL as the co-primary target or secondary target, and LPM emerge as a new target if the horizon trial comes out to be positive. So in summary, LDL is the primary target. It has a causal relationship with ASCVD. Non-HDL is the co-primary target. Lowering of LDL to very low levels like 30 or even 10 is very safe and provides incremental benefit without any side effects. If you lower LDL to Less than 65, it results in arrest of progression of atherosclerosis. If you lower it to below 50, it results in regression of atherosclerosis. And in the present era, LDL can be cut to any size by statin, ezetimibe, bempedoic, PCSK9, inclisiran, and by gene therapy forever. Icosapent trial is now available in India also, and pelacarsen is likely to emerge as a transformational therapy for LPA if the Horizon trial comes out to be positive. And the CRISPR-Cas9 technology is emerging as a very exciting modality and may be the future of cardiology. Thank you very much for your kind attention.